Good afternoon and good day, everyone. My name is Qistina and I'll be a moderator for today alongside my colleague, Mr. Nazran Zhafri. He's a co-moderator and will be moderating your questions during the Q&A session. Welcome to today's webinar on healthcare resilience, a very timely topic as the nation goes through another movement control order, an MCO, to curb the rising numbers of COVID-19 in the country. I'm very honored here today to be moderating and hosting two very big names this lovely afternoon, Dr. Co-moderator and Ms. Nadia Wan. But before I begin, I would like to invite Mr. Alizan Mahadi, the Director of Research, to deliver his opening remarks on behalf of ISIS Malaysia. Alizan, you have the floor.
Thank you, Qistina, and good afternoon, everyone, and a warm welcome to today's ISIS webinar on healthcare resilience, Malaysia's year into the pandemic, tried and tested. Thank you for everyone for joining us despite being in the week of Raya. So I really appreciate your attendance and your support for the ISIS webinar series. The topic today, I would say, quite unfortunately, is still timely, as many of us are currently still facing lockdowns. And while we have very urgent and short-term concerns facing our healthcare system, it's also very important to discuss about our healthcare resilience as a whole, and in the long term, in an effort to build back better and learn lessons from the pandemic. It has been over a year since COVID-19 reached our shores, and for the first few months, the country seemed to be reasonably successful at keeping cases to a minimum, leading to a great deal of praise internationally for our handling of the pandemic. Unfortunately, that was soon to change, as just like many other countries, the second and third waves in Malaysia has pushed the country's healthcare system into a very difficult predicament. As a result, even after a year into a pandemic and a couple of months into the vaccination of the population, Malaysia has seen record numbers of daily cases in the 3,000 to 4,000 territory. Further, for the third time, the MCO, Movement Control Order, was reintroduced in several parts of the country, including in Klang Valley and Kuala Lumpur. Thus, now is an opportune time to look back at the first year of Malaysia's experience with COVID-19 and ask several pertinent questions, such as how well prepared was our healthcare system for a major pandemic? And how did the country adapt and cope with the surge in COVID cases, especially during the second and third waves? And should there have been more inclusion of the private healthcare sector in the battle with COVID? And if so, how? Besides looking back at the past year, it is also important to look forward and understand what further challenges the healthcare system could face if cases continue to rise and if vaccinations are not rolled out as fast as hoped. Further, what has this pandemic taught Malaysia in terms of what we need to do to prepare for potential future pandemics? To discuss these important matters and more, we have two distinguished speakers with us today. Firstly, we have Ms. Nadia Wan, who is the Chief Executive Officer of Thomson Hospital, Kota Damansara, and also serves as the Executive Director and Group Chief Executive Officer of TMC Life Sciences Berhad. Welcome, Ms. Nadia. Secondly, we have Dr. Co-moderator, or as we know him, SK, who is a physician by background and also a known commentator and expert on issues related to public health with international experience in the public, private, non-profit, and think tank sectors. Currently, he specializes in health systems and policies and global health and holds fellowships at Chatham House, United Nations University, and ISIS Malaysia. Today's webinar, as identified earlier, will be moderated by both Tengku, Qistina, and Mr. Nazran Zhafri. And with that, once again, thank you for joining us today, and I will pass it back to Tengku, Qistina to moderate what I'm sure will be a really insightful session. Thank you.
Thank you very much, Alizan. Now, I'm very sure everyone's familiar with the big names that we are hosting today, but I would like to spend some time introducing them, if I may. As you may know, as Alizan has also mentioned, Dr. Sweeking Ko is a physician with international experience in the public, private, non-profit, and think tank sectors. He currently specializes in health system policies, as well as global health, and hold fellowships at very distinguished institutions such as Chatham House, UN University, and very proudly ISIS Malaysia. As how Alizan has mentioned, not only that, he's also previously held senior practitioner roles in clinical medicine, refugee and disaster relief, clinical research, and pharma anti-corruption. In these roles, he was based in not only Malaysia, but Singapore, Dubai, Shanghai, and Paris, covering more than 19 countries across Asia, Africa, Europe, and the Middle East. And our next speaker, Ms. Nadia Wan, is not short of being remarkable as well. As Alizan has mentioned, she is the Chief Executive Officer of the Thomson Hospital, Kuala Lumpur, Kota Damansara, my apologies, and also serves as the Executive Director and Group Chief Executive Officer, quite a mouthful there, of TMC Life Sciences Berhad since February 2019. She has also been recently appointed as the director of the Institute of Corporate Directors Malaysia in 2021. Nadia holds a Master's in Science in Public Health, focusing on nutrition from the London School of Hygiene and Medicine, and was awarded the Hedge Bequest, my apologies if I pronounce this wrongly, for the best student in public health upon graduation. She pursued her undergraduate studies in biochemical sciences at Harvard College while conducting research at Boston Children's Hospital with grants from the Howard Hughes Medical Institute. She is a proud mother of one who is passionate about transforming healthcare delivery and spends her free time juggling other commitments such as WEF, which is World Economic Forum, Young Global Leader, and is a vice president of the Harvard Club of Malaysia. Wow, that is really a long list of achievements from both our speakers. Now, before we begin, allow me to take a bit more of your time to make some very important announcements. Each speaker will be delivering remarks for about 10 to 15 minutes, after which we will then proceed with the question and answer session. Participants to this webinar are invited to use the Q&A window through the button you should have on your desktop screens in Zoom to ask questions. You can see it's just at the bottom there, and it's written as Q&A. Please take note that this is separate from the chat window. And without further ado, Nadia, you have the floor.
Hi, good afternoon, everyone. If it's okay, I could share my screen. Let's hang on here. Can everyone see my slides?
Yes, we can, Nadia.
Okay, right. So basically, I think having gone through this crisis for more than a year now, I think that looking forward, what does it mean for us here in healthcare in Malaysia? And for me, I think the primary message would be that it would be a shame to miss this crisis as an opportunity to make some structural changes in the way healthcare is being delivered in Malaysia right now. So basically, I think of it as a burning platform that the pandemic has really brought together a bunch of actors that normally perhaps would not have necessarily interacted all that closely together to actually do things differently. And I think if you can remember anything from my talk today is I hope this momentum doesn't go away because change is definitely required. So we know the effects of the pandemic and people ask me, well, how is healthcare doing? In actual fact, I think COVID has been slightly bad for business because primarily I think in the private healthcare sector, we are doing a lot of elective cases, but when you have a pandemic surge, we're forced to actually slow down on more profitable elective procedures and have to deal with basically life-saving procedures. And I'm sorry to say that probably in Malaysia right now, this is a situation we're facing where we have way more COVID patients than we have COVID beds to sort of take care of. And many hospitals, public and private, are looking at slowing down elective procedures for patients with cancer, with other illnesses. And, economists will probably be calculating the effect of this for a long time. So this is what we're facing now. And I thought I'll just take you through a little, overview of what the healthcare industry looks like from my perspective. We have actually a lot of players. At the core, of course, is the healthcare worker and the doctor and the patient. And then we have the institutions like clinics and hospitals. We have the supporting ecosystem like support services, diagnostics services, suppliers, and also payers, because in healthcare, the people who are consuming the services are not necessarily the ones paying for it, which is a very different dynamic, I think, from other sectors. And then around that, of course, we have the regulators, civil society, policymakers, and also global organizations. And I think that really what we have seen with COVID is that there's been extreme constraints in manpower. We have had issues, obviously, where we already had not enough doctors and nurses, and everywhere around the globe, people are scrambling for more healthcare workers. And we're also facing with challenges like the future of work. When we had the first lockdown, how did we cope with running a hospital where a lot of the administrative staff are not allowed to come to the office, switching to a more virtual way of working, which is really not something that we're used to in healthcare because this is a very hands-on business, literally. And so how do we look at retraining, redeployment, developing capacity, and coping with this new future of work? So, you've had stories in other countries where people were asked to you know, medical students were fast-tracked through their med school, and then you have people who are now switching from other industries like hospitality industry into healthcare, and of course work from home. And for the doctor, they also had to overcome a lot of challenges and issues, digitalization and decentralization of care, and changing the way they've been working and delivering care. So many hospitals, including Thomson, introduced you know, we had Thomson Hospital Online, which is basically a telehealth platform. And that was something that people had to very quickly get used to do teleconsultations, e-prescriptions, technology that has been around for a while, but culturally and with the mindset not really accepted. But I think this pandemic really accelerated that change in mindset, both from the healthcare provider and also from the patient. And then we also have this issue about clinics and hospitals having to transform the way that we work. So in private healthcare, and aside from digitalization and decentralization, there was then sharing of resources. You would have heard that, you know, loaning of ventilators to the public sector, and now during this wave, actually establishing a public-private command center to actually manage the scarce resource, which is critical ICU beds. So these were things that previously I think we would never have explored, but the pandemic has really brought us all together. And the issue of value-based care, when we talk about the cost of care for something like COVID, where you have an acute episode and you also have potentially something that is more chronic with long COVID. So, you know, people introduced a lot of different things, you know, loaned out ventilators. There was this issue of outsourcing non-COVID cases from government hospitals. And then on the public healthcare side, I think there was a focus on public health. I think there were a lot of unsung heroes, people who were doing contact tracing and public health measures, which are actually different, I think, from sort of what I would think of as acute care or giving treatment to people. So that was something that really came to the fore. Purchasing of services from private sector, I think this was happening in a small scale, but became actually somewhat federalized or institutionalized during COVID because of the scarcity of resources. And this is something I definitely hope will continue. We can see that happening with the vaccination efforts now, where the government is reimbursing private players to administer doses as part of the national immunization program. So we also expose the criticality of the supporting ecosystem, which a lot of people don't really think of when they think about the face of healthcare. In particular, I think with COVID, molecular diagnostics, genetics, testing came to the fore, and it really showed that we have a gap in terms of scaling up localization of the capability, and also the collaboration between the academic centers, public and private healthcare institutions. And very quickly, I think, scaled up the number of labs. They came up with SIMCA, which is the IT system that links up all the labs when we're doing the reporting of the results. So that was really important. Particularly, I think for suppliers, very early on, we saw issues with PPE suppliers, where when China closed its doors, it affected the global supply chain. And there was a lot of discussion about localizing supplies of critical healthcare consumables like PPE and now, you know, vaccines. So this is something that I think that many manufacturers are now looking into, many countries are now looking into as a matter of national security. And so we also look at the support services, the technology, IT, I think has come to the fore in terms of its use for contact tracing. I know there's been a lot of discussion about the HIDE system that was recently announced. Environmental concerns have come to the fore, particularly with COVID, which is an airborne disease, and we're looking at ventilation, things like infection control, and people were starting to look at, well, I have a COVID case in my office, who can help sanitize and clean this for me? And so there's really been an explosion, I think, in terms of the supporting services for healthcare. Oh yeah, and we even started working with developers who never really saw healthcare as a really particularly sexy IT sector, but suddenly realized that actually there's a lot going on that we need help in, and a lot of opportunity, I think, for a lot of startups. So we actually worked with a startup to come up with our Drive to COVID testing app. And I know that the government is also working on a few initiatives to see how we can actually ramp up our response relatively quickly using IT. Well, the case with the payers, it's more, I think, hopefully of them adapting to this value-based care model and moving at speed. We see in the US in particular, this accelerated the transition to value-based care simply because, you couldn't rely on fee-for-service when you're talking about something that affects public health. And with telemedicine reimbursement by private insurance companies, that caused telemedicine uptake in the US and Canada to really accelerate very, very quickly. So this issue of financing and whether or not it's covered by insurance is actually really important to the future success of new technologies and new changes in healthcare, something like telemedicine. So in Malaysia, I think the insurance companies have not yet really decided whether this is something that they will go for, although they have been making sort of inroads into looking at preventive health using telemedicine platforms rather than straightforwardly just reimbursing on the telemedicine consultations itself. But this is an evolving conversation that everyone should be having because I think it's really important for the sustainability of the industry. And last but not least, I think the governance piece is the biggest, the most complex, but also the most important. And from my perspective, what had changed in terms of regulators was that there was an increase in self-governance and monitoring simply because regulators could not keep up with the changes that were happening on the ground with the multiple waves. And so it became a switch for them rather than us applying for approvals to do things, for us to do what was required on the ground, and they would come and inspect and make sure that things were okay retrospectively. So more self-governance, which I think is a good direction, which would enable the industry to be a lot more flexible and agile. In terms of global organizations, I think very clearly there's a lot of knowledge sharing online. And very early on, because the whole world didn't know much about COVID. I think having those conversations and sharing of research, a lot of preprint papers was very essential for us to sort of formulate our response very quickly as we watched other countries like Italy face the pandemic waves, and so that we could rapidly learn and adapt our own response here in Malaysia. In terms of policy making, I think we saw a lot more intra-agency cooperation. That people, I guess, were forced to be open to a new paradigm. I think paradoxically, perhaps in healthcare, often we have a more risk-averse based policy approach because of the impact that health has on human life. But I think in this case, the speed of the pandemic really sort of forced people to be open to new paradigms, new ways of working, and really look at intra-agency cooperation, and something that I hope will continue after this pandemic passes. And last but not least, not to forget, I think civil society. We all know, as we focus a lot on the impact on health, but also on legal and civic rights, on community aid. And this really hit me, or us at the hospital in particular, when we see in the beginning, when people weren't sure, we had to provide support for some of these communities where, for example, a mother and her family would not be able to enter into a shelter without having a COVID test swab, and who would be paying for those. So there was a lot of issue, and we actually launched a COVID test fund to help protect the vulnerable during that time. And of course, now when the SOPs are a lot more certain, there was a lot more, there's less of an issue now. But in particular, I think in the beginning, when things weren't really clear, there was definitely a segment of the population that was made vulnerable. So what are my hopes for the future? I think strengthening of the entire ecosystem, definitely. rebalancing via partnerships. I think what has really been a welcome change is having a lot more collaboration from the ground up between public-private partnerships and also with other different stakeholders and players within the ecosystem. Definitely a whole of nation and whole of government approach to health is required. And I think health is quite fragmented in Malaysia. A lot of burden is placed on the Ministry of Health, but if we see and we drill down deeper, you can see that the Ministry of Higher Education is responsible for the supply of healthcare professionals. We see MITI being involved, Bank Negara being involved in terms of regulating the payers. And so I think that this whole of government approach and sort of like making sure that governance and stewardship of healthcare is not the sole responsibility of MOH is going to be very important. Otherwise, it would affect our ability to respond in a future pandemic. Decentralization and digitalization, I think, has been talked about a lot. And I think then the trend has always been there. Then the question is how fast do we get to that end state? And it really depends, I think, not just on the mindset of the consumers who obviously want more personalization and ease of access, but also from the providers and the regulators and the payers and everyone else in the ecosystem. And last but not least, data-driven, value-based care. So I see a lot of conversations now about seeking health information, from efficacy of vaccines to whether or not this is a hotspot, to you know, the cost of providing care, or we're looking now at how do we prioritize care, especially in an acute situation like this, deciding on very scarce resources like ICU beds. So a lot more conversation about data that's involving the whole of society and not just healthcare professionals is something that's been really, I guess, a really good thing that's happening. And I wish that we would do more in the future and we would involve more stakeholders as well. So that's my 10-minute whirlwind tour, I guess, of my thoughts about the pandemic. Yeah, so I'll stop sharing now and pass over to Qistina.
Thank you so much, Nadia. Wow, that was very insightful, especially to listen and understand how progressive and fast changing it is for the healthcare industry. Providers, lay people with a lot of something to think about. I'm really looking forward to a great discussion with questions from the floor later. But before that, I would like to invite Dr. Kaur to give his presentation. Dr. Kaur.
Qistina, thank you. Nadia, great thoughts. So similarly, I'll try to share my screen as well and hope that you'll be able to see it. Just a quick check. You can see me, hear me, and see my screen, Qistina?
Yes, I can see your screen. I can hear you perfectly fine. Thank you, Dr. Kaur.
Thank you. Thank you. It's a pleasure to be here with everyone again today, and proud and pleased to say that I'm a visiting fellow in ISIS, and I think ISIS has been really at the forefront of a think tank work for Malaysia, not only in terms of health, but also in terms of public policy, economic policy, and social policy over the past 1 year. And think tanks are a very important part of Malaysia's ecosystem, or rather the ecosystem of every country. So I'm pleased that we can have this kind of forums and this kind of conversations going forward. I'll keep my remarks brief, and maybe in the next, say, 7 to 8 minutes or so, just try to keep this to just the one slide that's on the screen right now. I would like to speak about Malaysia's health resilience. We'll begin by saying that health resilience does not have a metric. There is no, say, KPI, like a gross domestic product or something of that sort, for us to measure one country's resilience over another. So let's bear that in mind, right? That health resilience is a bit subjective. There are no firm metrics for us to determine what is health resilience. But I'll structure my thoughts into 3 broad categories. I'll begin with the box in blue on the left of the screen. That talks about how Malaysia, after a turbulent first year, as Alizan has mentioned, were just about resilient enough. The second thought I'll share is in the box in orange in the middle of the screen, that the current landscape in Malaysia right now can tip into disaster very, very quickly, and explore ways in which we can tip into disaster very, very quickly. And no amount of resilience will really be able to prepare us for something that could be, well, a disaster, depending on what you mean by a disaster. And then thirdly, in the box in green, on the right-hand side of the screen, I'll propose some solutions about how we can take the conversation forward, as well as avert the catastrophes and disasters that are kind of lurking around the corner, and ways for us to improve our resilience. In a sense, we have to perform surgery while running a marathon. So we'll take these three thoughts in turn. Let's begin with the box in blue, right, on the left of the screen. We've had a very turbulent first year. Malaysia had a very turbulent first year. And in that turbulent first year, we can see not only are we having a third wave right now, the number of cases are very high. This week was the deadliest week in Malaysia, with the number of people dying at its highest and fastest rates. The number of people in ICU are the highest that it's ever been, etc., etc. So I won't give you all those details because we're all kept appraised of it. It's been a turbulent first year, not only in health terms, but also in political terms, economic terms, even social resilience terms, as our social welfare net is fraying despite the 6 or 7 government fiscal injections that have come into the picture. But despite that turbulent first year, we remain resilient. My assessment, like I mentioned to you, there's no hard metric for resilience. I think we're just resilient enough. And we begin with Ministry of Health resilience. It's resilient in 3 factors, or it's very multifactorial. Because in terms of human capital, we're still at 270,000 people in the public health system in Malaysia, and a lot of them are feeling the effects of fatigue and burnout. Again, it's very difficult to quantify fatigue or burnout or tiredness, but when you see a lot of your colleagues, say, getting infected with COVID, or you're just working 24 hours a day, for example, it's inevitable that there will be a lot of fatigue and burnout. But the resilience for Ministry of Health can also be measured in terms of resources and equipment. So for example, without the benefit of data, we're not able to say what are our stockpiles, what are the supplies that we have for personal protective equipment, or the reagents needed for us to do the antigen testing. So for example, how many disposable single-use low-dead space needles do we have left for us to deliver the COVID vaccinations for the whole country? So we're not certain whether or not we are resilient in terms of resources and equipment. Finally, is the Ministry of Health resilient in terms of 3 routine services? Because COVID-19 is no longer an exceptional feature of life. It has become a routine part of the healthcare landscape. So you have COVID care, you have non-COVID care, which has to be decanted to private hospitals. Maybe elective surgeries are being postponed right now in a circular from the Director General of Health. Patients with cancer and diabetes and childbirth could be compromised. We don't know by how much, and we hope by very little, but almost certainly they will be compromised. And there's a second routine healthcare delivery that's being, say, impacted. And thirdly, we're putting vaccinations on top of COVID care and non-COVID care. And on top of all that, we have to find a way for us to transform our health landscape to become a little bit more digital and electronic. That is the resilient landscape of the Ministry of Health. But let's talk about the national resilience of Malaysia. It's also multifactorial. On the screen on the left, there's resilience in a social, mental, psychological, and economic status as well. There are some tangible metrics, for example, the economy, or the number of people who are unemployed, or the number of people withdrawing from their EPF savings and so on. So there are some tangible metrics. But in terms of intangible metrics, there are many. Perhaps we arrive at the conclusion that Malaysia at the moment is just about managing. Therefore, we can't take resilience for granted. But I'll elaborate in 2 ways, if I may, for not taking resilience for granted. The Ministry of Health frontliners, doctors, nurses, paramedics, and pharmacists, they are actually semi-military, paramilitary, or whatever term you prefer. Why? They operate 24 hours a day, 7 days a week, 365 days a year. They have discipline, they have loyalty, they even have a uniform. You can rely on them to deliver healthcare services for all of Malaysia. So in a way, they are the armed forces of Malaysia, and we can rely on them. But for how long can we rely on them? And we certainly should not take their resilience for granted. On a more macro scale for Malaysia, we've got a decreasing fiscal space. We're approaching the ceiling of our, say, debt to GDP ratio. We're forced perhaps to issue a bit more government securities these days. The uncoordinated policies that we have, notably in Hyde in the last few days, where Ministry of Science, Technology and Innovation does not appear able to coordinate with the National Security Council. Uncoordinated policies with a lack of a long-term exit strategy means that Malaysia has a very, very small room for mistakes. If we don't want to become like India, for example, today, or Italy in March of 2020, then we have to be aware that the current landscape can tip into disaster suddenly. Let's move on to the second box, yeah, the one in the middle. There are many ways for us to tip over. Here's a list of 5 short ways, and I'll rapidly move on. We have super spreader events. The DG of Health a few days ago showed the example of one person returning from Johor to Sarawak and causing 2,900 cases in Sarawak based on his, I believe it was a his, it could be a her, I'm not entirely sure, I'm sorry for that. But based on this person's arrival to Sarawak from Johor because he wanted to visit his family because there was a death in the family. That one visit costed us 2,900 cases and about 26 deaths. So super spreader events are very real in COVID. An overwhelmed intensive care unit, we may think that, the intensive care unit is okay, we'll preserve it, but it has knock-on effects, a chain reaction to high dependency units, which then has a chain reaction to general medical wards, which then has a chain reaction to all wards, and so on and so forth. So even just one event can have a chain reaction of events in a health system. We may have, thirdly, political or economic black swans. We didn't expect a change in government last year, maybe a general election or any possible political permutation or economic black swan could happen to tip us into a disaster. A slow vaccination program could lead to immune escape. What immune escape means is that the virus evolves in such a way that it becomes a little resistant to the COVID vaccination, COVID vaccines that we're able to provide to it. So we have to vaccinate as quickly as we can. Or finally, in the current landscape, we may not tip into disaster suddenly. We just sleepwalk into it, or we get death by 1,000 cuts. What I mean to say is in the following. In other words, in more literary words, right? Oscar Wilde was asked, how did you go bankrupt? And he says, slowly, then suddenly. In this landscape of Malaysia's health system right now against COVID, we have to be careful that we don't slowly and then suddenly lose all our resilience. Therefore, it's important for us to plan for a wave X. And a wave X is a wave that is a concept that I've sort of invented. And in this concept, we have to understand that there is a possibility that Malaysia's third wave, the wave that we are in currently, may not be the worst wave that we will find. That even after we beat this third wave, and we clearly go down to zero again, there could be a fourth, a fifth, and a sixth waves, because COVID is not going to go away anytime. And it's actually, I'm not interested in counting waves, because counting waves is like counting the waves in the sea. And it's just going to come and come until such a point where we have a clear exit strategy that may come in 3 to 5 years' time. So therefore, planning for a wave X, this exponentially large and catastrophic wave of infections for COVID is important. Subjectively, and without the basis of a lot of data, I don't believe that there is enough surge capacity within Malaysia's system. What if Malaysia has got a wave 2 times worse than the current third wave, and we will not really be able to sort of prepare for it? I'm not trying to be alarmist, and for those journalists and people who will be quoting this particular webinar today, let's not be alarmist, but we have to be realistic and practical by marshalling all the resources available to us to prepare for a wave X. Therefore, this worst case scenario planning must already be performed. And if it's already performed, which is great, then publicize the results of this planning and scenario planning by the government. Let's not, I think it's inadequate, grossly inadequate for the government to just assure us that they have the plan. We want to see the plan. And if you publicize the plan, you will then get civil society buy-in, citizens to understand and to build more trust in the government, rather than just assuring us that there is a plan. Show us the plan. And once there is such a plan, if it's implemented, we can then really involve a true all-of-society approach. Ladies and gentlemen, I've taken you through what my assessment is that Malaysia is just resilient enough and that the current landscape can rapidly tip over into disaster quite suddenly. Now let's look at the box in green, and I'll end here. A lot of this is actually not new, so I will not spend too much time. I'll give you a laundry list. The concept here is that while we are continuing to deliver COVID care, to deliver non-COVID care, and thirdly, to deliver COVID vaccines, it is a form of performing surgery while running a marathon. What is the marathon? COVID, non-COVID, and vaccines. What is the surgery? Doing all these other things that will help you build your resilience, not only for this pandemic, for wave X, but also for future pandemics. In the short term, ladies and gentlemen, dramatically expand human capital. I advise some medical students across Asia Pacific, and some of them in India are telling me that they're 2 years from graduation. So this is third year out of a 5-year medical program. state governments in India are asking them to become frontliners. I'm not saying that our third-year medical students in Malaysia need to become frontliners. We're not there yet, so let's not quote me on that. But the point I'm making is, let's dramatically expand the human capital. Let's use spare private capacity. Let's shift tasks whenever possible and have new graduates come into the picture as and when that's necessary. But we need to dramatically expand the human capital. Also, dramatically speed up the vaccination program. Thirdly, this exhortation by the government to follow SOPs will be made much easier if SOPs are coherent, they're predictable, and they don't change so frequently. Fourthly, we need more transparency of data. And finally, we need more and better non-MCO solutions. All of this is in the short term. But in the long term, a more coordinated all-of-government response. Now, we've all used this term repeatedly over the months. But yet we're still using this term. So more coordinated all-of-government response, for example, only the latest one is the HIDE system that was led to some uncoordinated responses from the government, also some unintended consequences. A more coordinated response would be helpful, especially a clear and predictable long-term exit strategy that doesn't rely only on MCOs. None of this is new, and I think multiple people have already said this, including the government. Now we just have to put this into practice. Ladies and gentlemen, happy to share my thoughts with you about Malaysia's health resilience as it stands today. Qistina, over to you.
Thank you so much, Dr. Ko. Wow, that was another heavy one, but very insightful and very interesting. Something to give us a bit of thought. We have a few questions from the floor, but I would like to firstly abuse my privilege as a moderator here and get the ball rolling by asking both Nadia and Dr. Ko on your thoughts on pandemic fatigue / burnout. You know, there have been reports in social media on how the population now has become lax. People are getting complacent with the SOPs, refusing to even abide by them to a certain extent. So, Nadia, if it's okay, what are your thoughts on pandemic fatigue, burnout, and whatnot?
Sorry, I need to unmute myself. Yes, definitely. I think pandemic fatigue is very real. I saw somebody ask a question about mental health amongst healthcare workers. Definitely something that needs to be looked into, not just for healthcare workers, but I think every segment of society is being affected in many different ways. And I think the solution to that is really, you can't have someone on high alert all the time. And so something like, I hate to use the example, but HIDE is really there. I think the purpose is to actually go with the flow and basically put people on alert when they need to be on alert. And then when it's not, then give them a sense that things are under control. But if the signaling is always to have on a consistently high level of alert, no doubt, I think for any human being, there will be some level of burnout or fatigue or indifference. And I think this is why many countries, when there was an issue with terrorism, had multiple levels of alerts, which they would then swing between red, yellow, orange, whatever color. But that is the whole purpose, actually, to signify that things have changed on the ground. We need to modulate our behavior, and this is the expectation of what you need to do when the situation becomes like this. So I think having that very clear framework is really important for us to manage this, because we know that the virus will become endemic. It's not something that will disappear all of a sudden. We will need to learn how to live with it. And this is part of a coping mechanism, really, when you talk about public health, is to have that clear communication, that alert and warning system, so that people can modulate their behavior accordingly, because to expect them to be on a consistently high level of alert, I think is wishful thinking.
That's very true indeed. Dr. Ko, what are your thoughts on this?
I agree with what Nadia has said about fatigue. Well, I'll share a biological fact, which I think will be helpful to every policymaker out there. The human brain is exquisitely energy sensitive. For about 5% of our body weight, it consumes about 20% of our calorie needs. And this is just the biology. The brain requires a lot of rest. Rest in policy terms, meaning make SOPs easy for people to understand and not raise the alarm level unnecessarily. And while I guess in more storyline terms, it's the boy who cried wolf. we can't cry wolf every day for 1.5 years, because at some point the rakyat are going to say, you know what, the government's not telling me the truth. So the high levels of alert are necessary, not all the time, and they should only be deployed when they're truly necessary. Obviously, what is truly necessary is always a matter of a subjective opinion and depends on individual judgment. But mental fatigue, I think it's a very real issue for biological reasons, and also because it's just a way human beings react to each other. So to the extent possible, let's go to a middle ground where we have a nice and steady level of alert, say a baseline level of alert, which should be more than before COVID, but certainly not as high as the level that the government wants us to be at all the time. I think it should be a lot more nuanced and a lot more targeted. We've had 16 months to sort of prepare for a lot more nuance and a lot more targeting in terms of our public announcements and SOPs, and I really think that we should do a lot better.
Thank you so much for that, Dr. Ko. I think this actually reminds me of how the UK, I believe, kind of categorizes as well as recognizes the different levels of threat. Well, in this situation, the healthcare security threat that is being posed to the community itself. And I think we will get into the questions, and I believe there are some few questions who are actually asking about practices from other countries. But before we get to that, I would like to give the floor to my co-moderator, Nazran, who will be highlighting some of the questions asked. Nazran, over to you.
Thank you very much, Qistina, for that. And firstly, I'd just like to thank both the speakers for both their very enlightening presentation thus far and deep and very useful insights. So we have quite a number of questions here already, but I would just like to remind the attendees that they can continue asking questions, and we have approximately 30 minutes or so to ask as many questions as possible. So because we're on this topic of because we are on this topic of mental health and we're talking about the general public fatigue, I like to focus more specifically now on the mental health with regards to our frontliners. And from what you have seen and what you have read, how has the mental health of frontliners been addressed and cared for during this period? And how can other stakeholders help address the mental health of frontliners? And this is also a question from Ms. Michelle Lowe. So thank you for that, Michelle. So Ms. Nadia, maybe you'd like to answer first?
So I think by and large, many organizations, health organizations have realized this fact. And in fact, even for Thomson Hospital, we now provide coverage for mental health support for all our employees to get aid. But actually, we don't really see a lot of massive demand amongst the healthcare workers. Primarily, I think the strain that is coming is not actually from just direct patient care. It is also from all the social issues that are affecting them. So remember, healthcare workers are just like any other person on the street, you know. When schools are shut, it affects them. If their husband loses a job, it affects them. You know, domestic violence affects them. So, and I think even more acute because in healthcare for our workforce, predominantly female, of childbearing age. And so a lot of these pressures are actually weighing down on them. So yes, they do have pressures from managing clinical issues, managing pandemic, but even more so, it's a lot of the societal issues that are imposing pressures on them, which is similar to what every other person is also facing. And what are the sort of like infrastructure that we can provide to help support them? I mean, there are things that people are doing like, you know, the government allowing daycares to operate is really good example, because without that, I think really half of the workforce would not be able to continue working. So these are some of the things, but I don't have the answer, but I think that the issue is a lot more complex than just the burnout of having to deal with, you know, very acute patients in the ward.
Thanks for that. Dr. Ko?
Thanks, Nazran. Michelle, thank you for your question. And I think it's a question that will be also very good if it were directed to the Ministry of Health as well. I'm sure they're doing a lot. We would like to know what they're doing for their frontliners. So I don't feel placed to answer on behalf of the Ministry of Health because my information is quite secondhand. And I think the Ministry of Health really should come up with the assurances that they are doing whatever they can to take care of the mental health of their frontliners. I agree with everything that Nadia has said. So let me add on to say that the treatment, I guess, to answer the second part of your question, Misha, which is how can other stakeholders like policymakers, civil societies, clinics, and hospitals address the mental health of frontliners during this pandemic? I guess it is also your employer's responsibility. So in this case, the Ministry of Health is the employer. Let's set that aside. They have a tremendous responsibility. I hope that there are a lot of public statements to show how they are fulfilling that responsibility. People like Nadia and the CEOs of private hospitals are taking care of frontliners as well. Maybe I'll offer some suggestions for, say, civil societies, private companies, and members of, say, the lay public. What can we do? We can make it slightly easier for our healthcare professionals. Like, for example, in some countries, healthcare professionals go to the front of the queue if they're going to, say, do their laundry or buy a coffee or something of that sort. And if there's some small, say, policies or decisions that a business will be able to do to make life slightly easier and to show appreciation for the frontliners, I think that would be appreciated. It's better than lighting bridges in blue, shall we say. Nazran, over to you.
Thank you very much for that, Dr. Kaur. That's some great answers. I thought it was very important to bring up this question and issue of mental health for the workforce, because sometimes I think that's forgotten or neglected, just how much they have to go through on a daily basis, because they really truly are heroes for us. So what I like to do next is now focus on what's going on right now in terms of the high number of cases that's getting more and more worrying as the days go by. But we have a question here from Mr. Haris Zainul, who asks, do we currently have the sufficient capacity to deal with COVID-19 patients? And will this capacity be able to cope if there is an even bigger increase in case numbers? And if it's not sufficient, why is that so? And how can this be overcome? So maybe I'll ask Dr. Kaur to go first this time.
Thanks, Nazran. Thank you, Haris. Haris, you've hidden 5 or 6 questions into a short one, so I love that. Let's give you an overall answer first, and then go parse it one by one. Yeah. The short answer to your question overall, Haris, is it depends. It depends on what you mean by sufficient capacity. What is this? Say surge numbers of COVID patients that will be coming in, and it also depends on the how you want to treat COVID patients, so to speak, as part of the overall government policy. So the short answer is it depends. But maybe I can answer also in instead of going highly specific, because short answer is I don't know. Depends on so many variables, right? But maybe I'll give some organizing principles. The first organizing principle is transparency. Without the data from the Ministry of Health, we will not be able to ascertain whether or not Malaysia will or will not have the ability to handle surge X or wave X whenever it comes. And let me just use wave X as a concept that will anchor the conversation a little bit. So the first organizing principle is transparency, so that we can plan. Another advantage of transparency is that it tells the citizens of Malaysia not to take this for granted, and also to prepare and to help the Ministry of Health if and when the Ministry of Health does need help, number one. Number two, COVID patients mean different things. As you might know, as everyone might know, stage 1 to stage 5. And approximately 80% of patients in general are stage 1 to 3, where they don't need care or close care in a hospital. And stage 4 and 5 are the ones who need close care in the hospital. So we might need a way for us to triage stage 1, category 1, 2, 3, or stage 1, 2, 3, and 4 and 5, and separate them. It's possible for us to create a vast amount of surge capacity for us to house patients who are in categories 1, 2, and 3. For example, the hotels in Malaysia that are not currently utilized or utilized well. And instead of putting them into a pusat quarantine and pusat rawat quarantine, PKRC, pusat quarantine and rawatan COVID, we can also utilize say existing hotels, and that could dramatically expand the capacity that we can in order to have patients in stage 1 to 3. For stage 4 and 5, it's a little more complicated, obviously, and we may need to look at whether or not we have the capacity to deal with stage 4 and 5 on a more state-by-state and district-by-district level. So for example, although on average Malaysia may have the capacity, but there is a surplus capacity of beds and ICU beds and anesthetists in the Klang Valley and the west coast of Peninsular Malaysia, but less in Kelantan and Sabah. So it again depends on geographical distribution as well. For surge capacity, we may need a more modular, say, distribution of health professionals, and the more modular, say, shifts of assets as well. Maybe even recruiting assets from the private sector as a contingency plan. In the emergency declaration that was announced in January this year, there was a lot of talk about how we want to get the private sector involved. But until today, and maybe Nadia will share some thoughts as well, until today, at least to me, it does not appear that the private sector is actively engaged in the fight against COVID today during the emergency versus 1 year ago when there wasn't an emergency. Haris, so that's a bit of the explanation to your question, Haris. Over to you, Nazran.
Thank you for that, Dr. Koh. That was very detailed. I'd like to ask Ms. Wan Nadia if she has anything to share on this question.
So if you ask whether we have enough capacity, the answer is it's a pandemic and it spreads exponentially. There will never be enough capacity if we do not control the spread. And what we are seeing in the situation now is that very critically in the Klang Valley, we are at capacity, which is why I think there was a viral letter going around from the DG about trying to open up more beds. But the reality is that it's all a compromise. If we open up more COVID beds, it means that in reality, the care for non-COVID patients will have to be put on hold, will have to be slowed down, because that's all the resources that we have. So I think that this issue of whether we have enough capacity, it's never going to be enough. And we're definitely not seeing enough right now in the Klang Valley, even though, as Dr. Kaur said, this is where most of the resources are concentrated in the country. So the the control measures are actually extremely important because the numbers can multiply overnight in a very, very big way. And that is our main reason right now. So central coordination of resources is something new that they're trying to do to try and maximize the utilization. But the reality is that at the rate that we're growing right now, it's going to be very difficult to cater to that demand for health services. Does that answer your question?
Yeah, that sounds very detailed, and thank you for that, Ms. Nadia. I think that's a great answer. So what I like to do now is focus on what's the sort of the hot topic in the last week or so. So of course, Klang Valley ITES and KL ITES, and basically now as the days go by, more and more of the country, that frustration with this need for a third MCO. And also over the weekend, of course, there was this whole uproar over the issue of this suddenly out of the blue current height system and its major impacts and how reliable it is. So we've got quite a number of questions in the Q&A on this topic. So I'd like to combine two attendees' questions and ask, firstly, from Shannon, who asked, what could have been done differently since the first big spike back in September last year to get things under control? Should we have had a repeat of a strict MCO back then, like we did in March 2020, instead of what was done over the last number of months, i.e., loose tightening, ad hoc changes here and there? So that'd be the first part of the question, which is what could we have done since essentially like the Sabah elections or the second wave? And the second thing to ask is right now, the question about that height system, how much faith or confidence do you have in the height system? Do you feel it's, from what you know, precise enough to pinpoint truly high risk locations? So I guess I'll ask Ms. Wan Nadia if she can go first.
So I think the first question was about height, wasn't it? In terms of the algorithm, I think like any system is, when you start, it's not going to be that precise. It just gets more precise the more you use it. But I think height is very important for us to modulate behavior. The whole issue that we're facing right now, and we know we talk about adherence to SOP, but it's not just that strictly whether you're passing the test of ticking off whatever the SOP requires or not. This is a live virus that is circulating in the community, and the whole thing about living with it is that you need to be either pressing the accelerator or lifting off, not pressing on the brake or lifting your foot off the brake. And a system like HIDE would allow us to do that in a sense that there is a heat map, And if things are getting a little bit hotter, we all need to, like, you know, take a step back, let things go back down to normal and go back again. And this process can be over a very short period. The problem with a lockdown or a standard lockdown is that it's a nuclear option. It's the option that you take when you have no other option because the numbers are just spiraling out of control. And that is not an option that you want to pull out of your pocket regularly. So I think that that's what the frustration is. So HIDE and similar systems in other countries like Taiwan is meant to actually guide the population so that you don't get to a point where you have to call for a lockdown, but you have to send a very clear signal, going back to our discussion about fatigue, that now is the time that you need to step off, right? Like, yes, we have consistent SOPs, but there's a time where we think like it's okay to go to this location, and then maybe because the number of check-ins and the number of people that would lead to some sort of concentration, please stay away from that. So modulating that behavior, I think a system modulating that behavior is really important. So that is HIDE. The second thing is testing. So what we see is that there are a few sites that are causing a lot of cases. So with HIDE, we hope that, you know, we minimize those number of sites that will become this catalytic kind of a cluster or super spreader kind of venue. The second thing is with testing. There are a few people who are actually, a lot of the cases are caused by people who are not complying to the self-isolation and self-quarantine. And we see this happening in healthcare all the time. You are a close contact to someone who is positive. You went for a test, you are waiting for the result, you are supposed to stay at home and isolate yourself. But we find that without that positive result in hand, people think that it's okay to go out. And the problem with COVID is that when you are in the initial stages of infection, it seems that you are not ill at all. People assume that they are healthy, but they are spreading the virus. They don't have a positive test result in hand that tells them that they're positive. They think that they're safe and they're going out and spreading. That is the issue with this virus in particular, if you compare it to a virus like Ebola. Now, what can we do? Things like at-home testing or more widespread access to testing. It may not be 100% accurate like PCR, but the reality is if we can capture even the 80% of people who would have been infectious and tell them that you are positive, you cannot leave the house, then that would go a long way in sort of like mitigating the spread of this disease. So I definitely welcome and look forward to the at-home testing kits and lowering the cost of testing, widening the access to COVID testing, because I definitely think that this is another important way for people to learn how to modulate their behavior.
Thank you very much for that, Ms. Nadia. I'm also wondering if, to go back to one of the questions just now, regarding the spikes in September and how the authorities handled the situation with an MCO that was a bit loose and not very strict, and then over time they loosened it even more. Do you feel that something else could or should have been done back in September to prevent what's occurred right now with the high spike in cases and another MCO 3.0?
Yeah, so I think the problem maybe with the MCO is that you are trying to put very strict parameters, right? It's either this or that. You can open or you cannot. But the situation is a lot more dynamic than that. And so I think the issue is that it could have been a lot more dynamic in terms of showing and signaling what are the behaviors of people, whether they should continue to do this or they should reduce doing this and do something else instead, rather than just focusing on a very narrow set of parameters, which is basically the R0, the number of cases, the number of deaths. This does not translate into concrete behaviors that we expect the public to practice. Secondly, I think announcement of clusters. People fixate on factory clusters, but the reality is that when they announce and say that the cases are sporadic, it means that they can't even trace it to a cluster. They can't trace it to a particular index case. It's already in the community. So what you can do is that everybody has to modulate their behavior. And again, it's more of a cycle of tightening and loosening and giving that signal to people. But by just following on SOPs or lockdowns, it's very difficult because the SOPs itself are very black and white. It doesn't allow you to change one day or the other. I think that's what got people frustrated, right? It's because like one day the SOP was like this, the other day SOP is like that. It wasn't able to keep up with the changes that are happening on the ground. So what's more important, I think, is that if you have something measurable and you say that when it reaches this point, if this place is designated as a hotspot, then stay away, and people will, you know, and then they can come back again. But it's not to say like whether you can open or close. So I think being a bit more dynamic, being a bit more flexible, having a very clear communication of what is the behavior that is expected of people when there is this particular hotspot or cases that are found here, so that they can also self-regulate. I think that that's really important, rather than just saying that this is the SOPs. I mean, we can understand where the SOPs come from in terms of like wanting to reduce crowd density, you know, wanting to stop spread from one district to another. But in terms of communicating why, and then the understanding behind that, so that people understand the objective and they can modulate that behavior, I think in the long run, that's really important. And without trust, I think in the government, that is the biggest gap of all, because people are immediately suspicious of whatever is being announced. They think that they're being treated unfairly. And so it becomes increasingly difficult, I think, for them to communicate the reasons and the science behind it. So this is something that they really need to watch and figure out a way to address.
Thanks for that. It's very detailed answers. Thanks. Dr. Koh, can I call on you to answer the two questions?
Thank you. I like a lot of what Nadia has said, so allow me to build on it. To Shannon's question, hello Shannon. Shannon, many people and many questions in the chat group right now in the Q&A section, right, are asking what can we do differently, what can we do? And that really shows that all of us want to have a sense of control, a sense of agency, that we feel that we're a part of this together. So maybe instead of providing a list of what we can do, I'll provide some, again, organizing principles, right? The first organizing principle for us to consider is that the government strategy needs to be clear. And I mean, do you want to achieve 0 cases? And if yes, tell us that you're going to achieve 0 cases, and tell us why you think it's a good idea, and tell us that you're willing to accept the cost of achieving 0 cases. Because to achieve 0 cases, while it's possible, will engender a tremendous, well, I can even use the word suffering on the rakyat for any number of reasons. So we must be clear in Malaysia that personal opinion, a 0 case strategy is not practical, not desirable, and therefore we should not use it. In fact, we should actively, explicitly abandon a 0 case strategy. This does not mean that we're going to have all sorts of cases around the world, but we'll tolerate a minimum level of cases with vaccinations, with movement restrictions, and with non-pharmaceutical interventions. We should be able to keep the cases manageable on an endemic level. I'll give some examples of endemic diseases that happen all the time and yet doesn't threaten to overwhelm our health system. Dengue, malaria, tuberculosis, and HIV/AIDS are examples of endemic diseases that does not overwhelm the population of the healthcare system of Malaysia. So I think Malaysia should explicitly abandon the 0 case strategy, because right now, all our policies are implicitly towards 0 cases. 1. 2, the philosophy of it is to manage behaviors, not restrict actions or activities. So this is based on what Nadia has mentioned just now as well. After 16 months of the pandemic, our focus, Malaysia's government focus, should be on changing behaviors, not restricting activities. MCOs, SOPs, these are all measures of restricting activities rather than to modulate behaviors. So I think there's a lot of, say, philosophical changes that needs to be done in the Malaysian government's public policy responses. Thirdly, we need boring, predictable, stable, reliable government. What I mean to say is no drama or flip-flops of SOPs. Make one set of consistent SOPs and make it easy for people to understand. Don't, I mean, we really shouldn't really be having egos and people who want to be heroes in this particular respect. I think teamwork is very important. Therefore, a boring and predictable and stable and reliable government policy making apparatus is needed. That's the third one. The fourth one I'll make is an observation about the SOPs, right? Shannon's direct question is one of the non-MCO solutions that we will have. And I'll say targeted MCOs are important. We need a basket of solutions, targeted MCOs. better and more coherent SOPs with equal standards of enforcement and no double standards of enforcement. And I'll add one more to say that if the SOPs keep changing all the time, you're spending energy and time trying to tell the population of Malaysia what is the SOP, when after 16 months of the pandemic, you should be telling them why the SOP. And when you tell people why they should follow a particular SOP, it's easier for them to understand, and then they'll be more likely to follow. So in the beginning, you tell them this is what you need to follow, but sooner or later, and in fact sooner rather than later, you have to tell the population of Malaysia why you need to follow the SOP. Not just here's a set of SOPs and they change all the time and we expect you to keep abreast of all of them. These, I think, are the governing principles of what else we can do better. Nazran, over to you.
Thank you very much for that, Dr. Kaur. So yes, it's great that we've covered the topics of MCO and height, hot topics right now. And I guess another topic that can be considered without doubt very hot right now is this question about vaccines. So we've gone into sort of a second month of vaccine distribution and vaccine being carried out on the public. And I guess the big question, we've got one attendee here who has asked, what are your views with regards to how the vaccine distribution has been carried out thus far? And firstly, so how do you see the government's approach to this? And then also from the rakyat themselves, the public themselves, what are your thoughts in terms of the public participation? Are you encouraged at how quickly they signed up, how they've responded to it? So yeah, what are your thoughts on the issue about vaccines right now? Dr. Kaur, if you can answer first.
Thank you, Nazran. So an anonymous attendee at 3:02 p.m. For those who are interested in looking at the Q&A section, has asked this question. So thank you for the question. It's a very broad one. So maybe I'll structure my comments saying one big picture comment and one very granular comment. So the big picture comment is to compare Malaysia against the vaccination speeds and successes of other countries as well. And here, Malaysia's middle of the pack. And I think given the strength, sophistication, capabilities of our health system, I think we could be, well, if not front of the pack, then certainly in the chasing pack, right? So we can do a little bit better in a few ways. So that's a big picture when you compare against countries of a comparable population and income level, especially income level. And maybe if you want to put in a third metric, countries of a comparable, say, disease severity at the moment from a public health epidemiology perspective. Let me set that aside. In favor of one very granular comment. I think that's well, in the beginning, I thought that there was going to be a problem with vaccine confidence in Malaysia, but I think that vaccine confidence in Malaysia is perhaps less of a problem than many of us had originally feared, including myself. The take-up or the, say, very good reaction to the AstraZeneca opt-in system, although it's a very small number of 270,000 doses only, indicates that there's a very large pent-up demand for vaccines in Malaysia. So the quicker we can get vaccine supplies in Malaysia in the short term, I think the better it will be for the vaccination program. I'll end with one say suggestion for the future. This suggestion for the future is about round 2 of vaccinations for Malaysia. We already have to start thinking about round 2 of vaccinations, which means that either we start procuring again from the global supply chains, or we start developing our local industries, including the necessary technology transfers, patents, and so on and so forth to enable us to have domestic manufacturing over here in Malaysia. So that's my suggestion for the future. And I'll end with a final thought over here. Vaccination programs are great, but perhaps something that's more important is for us to ascertain who has adequate protective immunity. From an immunology perspective, protective immunity is not easily measured. In fact, B cell function, T cell function, natural killer cell function, and I've had to educate myself on this very recently, is all very complex. That's my point. And there may never be one single test for the amount of antibodies or T cell or natural killer cells that will be adequate to confer protective immunity. But my prediction is also that in the coming weeks to maybe months to a year or so, the conversation will shift towards vaccination round 2, as well as some measure of protective immunity. Over to you, Nazran.
Thank you very much for that, Dr. Kaur. Ms. Wan Nadia, could you share your thoughts on the vaccination situation in Malaysia right now?
So just building on what Dr. Kaur said, obviously supply constraint was one of the initial issues that we face, and BioNTech has announced that they're setting up a plant in Singapore to manufacture the mRNA vaccine. So hopefully Singapore will look on us favorably for future vaccine supplies. But I think one thing that people don't appreciate is that although the vaccines are federally procured, the administration of the vaccinations into people's arms is actually decentralized to the state health departments. And very quickly, you can see the difference between different states. A lot of people who were actually voicing their concerns on social media based in the Klang Valley obviously live in Selangor and Kuala Lumpur, states that have very high density of population, where the state health department was struggling actually to provide adequate coverage to the large number of people, the large resources that needed to be mobilized. So you could see that states with a relatively less dense population getting further ahead with their vaccination rates. And so I think then it also becomes a bit difficult for them to communicate, because different states were then empowered to do things differently in terms of scheduling, in terms of prioritization, how they wanted to roll it out. And so that could also cause distrust, I think, amongst the population, unnecessary angst that's going on there. The second thing, I think, anti-vaccine sentiment. Obviously, I think community engagement is really important. So I think that as vaccination rates pick up, I think definitely perhaps the vaccine confidence will increase, and we see more and more people at the community level, primary care providers, NGOs, teachers. Really, you have to recruit everyone to have that conversation. It's not enough just to slap a fake news stamp on it. It's really about building that trust and having that engagement at an individual level with that person to make them understand, about the purpose of vaccination. So rather than having a too top-heavy or top-down approach, really working at the grassroots level to build that confidence is very, very important. And of course, a lot of people asking about privatization of vaccinations. I think that obviously at the present moment, the private healthcare players are participating in a national immunization program. The expectation is, of course, when vaccine supply stabilize, which we expect it to be towards the end of the year, then this issue of choice comes into play. People want, as we can see with AstraZeneca, people want to be able to pick the vaccine. They want to be able to pick when and where they receive that vaccination. So I think that also has an effect in terms of the acceptance of the vaccine. And so I think that this is an ongoing conversation that we're having with the Ministry of Health. And I think it's really important, particularly for sustainability of the program for the long term. There are people who are willing to pay for vaccination period. There are people who are willing to pay for different kinds of vaccines. Obviously, there are also questions about equity and fairness, but I think at the bottom line is they need to be very clear about what the objective is. And I think that with vaccination, it's to vaccinate as many people as possible so that we can achieve herd immunity. So let's not lose sight of that fact as well.
Okay, thank you very much, Ms. Nadia. Unfortunately, time is up for the Q&A. It's really flown by, and just want to say thank you to all our attendees and our speakers for all these, both asking and answering these very important and essential questions. So what I'll do now is pass the floor back to Qistina, my colleague Qistina.
Thank you so much, Nazran. First, I'd like to apologize to our participants if your questions went unanswered due to the time constraints that we have. Please feel free to send us your questions to Nazran or myself. Our emails can be found on ISIS website under experts itself. Otherwise, I think Nadia and Dr. Kaur, if you'll be open to receiving these questions from the participants, do let us know. But before I end, I would just like to give our speakers an opportunity to wrap up just about a minute or two if that's possible, because it's already 3:47. We're kind of chasing a bit after time, but I think it's important that the speakers have the last say itself on what they have on the discussions that we've had this afternoon. Dr. Kaur, would you like to go first?
Thank you, Qistina. Well, special thanks to ISIS as well as a start for having this event about resilience. Resilience is one of those things where you cannot ever have a mission accomplished banner next to resilience. It's not a metric like we've achieved 80% population coverage of the vaccine, we've accomplished our mission. Resilience is a moving target. And because it's a moving target and it's a subjective and it's difficult to measure, and there will always be, shall we say, a wave X that's just around the corner that's worse than whatever worst case scenario that you're thinking of, it must always, in a sense, keep us on our toes, but keep us on our toes in a way that doesn't paralyze us with fear, with anxiety, with dread and anguish, but to approach the concept of resilience in very open-minded ways, that better to be prepared than to be sorry. Better that we're able to have all this surge capacity and stockpiles and reservoirs of not only resources, but also human capital. Not only that, but also goodwill from the public. All these things are built up over time. Think of resilience as a bank account. A bank account that if you continually put deposits into it, you'll be able to withdraw when the time is right. Over to you.
I really like that analogy. Really, really easy to understand. Thank you, Dr. Kaur. Nadia?
Yeah, I think overall, where the overarching lesson really is about trust. It was trust between the public and private partnership, trust between the public and the government. And we really see that I think communication is key in order to ensure that people are able to respond adaptively, to have resilience to face the challenges that they are facing, and to try and avoid having too much of a top-down approach. It really doesn't bode well, I think, if that's the kind of direction that we are heading towards. And so I hope that people, rather than just saying what they need to do, we communicate the why, so that they understand, why do I need to isolate myself? Why is it that I need to wear a mask? Why is ventilation important? I mean, if they don't understand the very fundamental facts about transmission and the reasons why, and you're just telling them you have to do this, then compliance is going to be low, and people are not really aware of the important parts that they need to be aware of. And so this really boils down to the communication and the trust that people have with authority or government, or the source of information that they're getting it from. So I think this part, we really need to relook and review our approach in terms of public health in order to make it a lot more sustainable in the long term, because we all agree that COVID is here to stay.
Thank you so much, Nadia, for that. I think trust is something that isn't actually being discussed very often. So it's very nice to be given that perspective. And that completes our webinar for today, everyone. I'd like to firstly thank both our speakers, Ms. Nadia Wan and Dr. Kaur, for making the time to be with us today on a Raya Week on an afternoon. But most importantly, I would like to thank the participants and audience, everyone, for such a stimulating and robust session. Before we end, if I may, I'd just like to inform you on the 4th of May on managing humanitarian crises. And last but not least, I'd like to wish everyone a Selamat Hari Raya Aidilfitri and happy holidays. Please stay safe, everyone. Thank you so much. Bye-bye.
Thank you. Bye.
Kami daripada Public Affairs and Corporate Services Tax Unit ISIS Malaysia ingin mengucapkan Selamat Hari Raya Aidilfitri. Maaf lahir dan batin.